Hello everyone, my name is Olivia Santos and I'm doing my Spring 22 Honors Project with Professor Longest and Professor Verdery for my EMS 105 class. This project is about broken heart syndrome and I'm going to take you on an inside look about what this looks like to us in the EMS field and hopefully raise more awareness about this extraordinary condition. For those of you who may not know, broken heart syndrome is a temporary heart condition that can be caused by stressful or emotional situations. This condition usually presents almost identically to a myocardial infarction or an MI and is also known as a heart attack. Broken heart syndrome is commonly mistaken for a STEMI, which stands for ST segment elevation myocardial infarction, which we will review later. Broken heart syndrome is not diagnosed in the back of the ambulance, but can be diagnosed in the hospital following several tests. Different procedures and surgeries can be used to treat heart attacks, but they are not useful in the treatment of broken heart syndrome. In the heart seen through cardiac imaging, the left ventricle may appear to be larger than normal because the walls of the ventricles have become weaker. Because the walls of the ventricle have become weaker, cardiac output to the lungs and the rest of the body is lessened, which can in turn affect vital organ function depending on what side of the heart is affected, which is usually the left side, which pumps blood coming from the lungs to the entire body. Broken heart syndrome may also be known as stress or Takotsubo cardiomyopathy, and this name comes from a Japanese pot used by fishermen for trapping. When the left ventricle in the heart changes its shape as a result of this condition, it looks similar to the pot used by the Japanese fishermen. Broken heart syndrome is being studied and recognized more often than it has before because of the evolution of medical technology and testing. A case study from 2007 focused on 4 patients of different backgrounds who were diagnosed with broken heart syndrome in order to determine the clinical similarities of this syndrome and use them for future studies. These characteristics are also compared to existing information on broken heart syndrome and its characteristics. If research studies like this continue, then there may be improvement in the awareness and early identification of broken heart syndrome in the emergency medical field. A question that remains about broken heart syndrome is whether there was a rise in cases since the start of the COVID-19 pandemic because of the increased stress of the population and the effect the virus has had on people of all ages. For this project, I have conducted 2 interviews, one with the EMS medical director for Chesapeake and one with a patient who has been diagnosed with broken heart syndrome. The answers to the questions asked in the interview will be evaluated and summarized to better understand the physiology of broken heart syndrome and how it may present in patients we see in the emergency field every day. This condition will also be compared to normal functioning of the heart in a healthy human body. The interview questions were split evenly between the 2 interviewees between the following categories. I have chosen to interview Dr. Thomas Chacon and Mary Ann Chacon, which they are siblings, and in the following interview questions, the answers are italicized. We will first review my interview with Dr. Chacon, and a fun fact about him, he was the very first provider to bring a cardiac patient to the cardiac cath lab in the hospital when it was first being used. He brought the patient in under the impression that his patient was having a STEMI, but later found out that they were actually suffering from broken heart syndrome. Dr. Chacon has been in the emergency medicine field for 37 years. He attended med school in 1974 through 1979, followed by an internship and 2 fellowships. He retired in October of 2019. He was very intrigued by the manner, office, and professionalism of his family medicine doctor, which is what inspired him to join the medical field. His family doctor also was a general surgeon. The biggest challenge that he's had in this job was the misinformation being pushed out to the public during the COVID-19 pandemic. Dr. Chacon's medics were reading and believing things they saw on the internet or from unreliable sources instead of doing the medical research or using medical references, which he found to be very frustrating. There was a lack of belief in vaccines and the pandemic itself. He stated that to him it was more disappointing than it was challenging because he felt that he couldn't accurately address the problem. Aside from the challenges, his biggest reward is that it is engaging and lots of fun. Chacon loves being able to talk to patients and having those spectacular and memorable saves. And because of his role, he also loves that he is able to give his people guidance and good advice. Dr. Chacon attended 4 years of college where he earned a traditional degree in science, more specifically a bachelor's degree in biology. He attended 4 years of medical school, and for his internship, he initially started in family medicine. He stated that his fellowship was a very hard position, but he also had a fellowship in critical care. He worked at Easton Memorial and Dorchester General when it was a general hospital. He was very well known by the providers who came into the ER at the hospitals, and when the previous medical director resigned suddenly in 2010, that's when he was approached about the position as medical director for Chesapeake College. Dr. Chacon would see an average of 7 STEMIs a month, whether it was by walk-in or by ambulance, and would see at least one of them, but not all of them. He had a lot of involvement in certifying the hospital cath lab. Broken heart syndrome only represents 1 to 2% statistically of patients that present as a heart attack. Broken heart syndrome patients will have acute coronary syndrome symptoms, such as the chest pain and the shortness of breath, for example. There will also be the ST segment elevation in the EKG, looking very identical to a STEMI. The only difference is that broken heart syndrome has no lesions in the coronary arteries. They are actually pretty clean. In the hospital, cardiologists can do more labs and find the catecholamine levels, which, if they are reduced, such as in a stressful situation, then it can induce microvascular spasms and stun the myocardium of the heart. Dr. Chacon stated that the most common causes and trends that we see to broken heart syndrome are stress, which can be physical or psychological, genetics, and mimickers of broken heart syndrome, which can include cocaine-related acute coronary syndrome and myocarditis. It is becoming more evident now than it has in the past because there's now a registry of broken heart syndrome cases. There are also more cardiac tests readily available, and the availability of diagnostics are increasing, and these include angiography and echocardiography. And every cardiac patient that comes into the hospital gets them, and every STEMI patient immediately goes to the cath lab. Now we will review my interview with Marianne Chacon, which was the patient that had broken heart syndrome. Marianne did not have any heart conditions or other cardiac history before her diagnosis of broken heart syndrome. She does believe that her diagnosis was a result of a respiratory virus, non-COVID related. The virus she believed to have picked up from her grandson or possibly from traveling. And although the virus alone may have caused her to be diagnosed with broken heart syndrome, there could have been some stress factors associated with her diagnosis as well. Marianne's pre-diagnosis was a myocardial infarction, as stated before, is also known as a heart attack. Her enzymes and labs were normal, but her EKG was abnormal, and mentally she had the idea that she felt like she was going to die. She presented with chest pain, diaphoresis, which is sweating, weakness, and tachycardia, which means a fast heart rate. The pain that she had, she stated it started on the left side and radiated down through her arm and to her lower jaw, which is commonly seen in patients with STEMIs and with myocardial infarctions. She also had abnormal heartbeats, which she stated felt like it was skipping, and the pain that she had was at least an 8 out of 10. These symptoms that she had lasted for about 6 months and eventually became her new normal. Every other day, she stated she would have episodes of tachycardia and skipping. So Marianne was not taking any cardiac medications before or after her diagnosis. At the time of the diagnosis, those who were working on her considered cardioversion, which is basically electrical therapy to get her heart rhythm back to normal. Through the ambulance, she went through standard care that we present with cardiac patients. This includes an IV with fluids, a 12-lead EKG to see all sides of her heart, oxygen, and a blood draw through her IV. She also went through lots of testing at the hospital, and she was immediately sent to the cardiac cath lab, and her enzymes were shown as normal. They did every cardiac test they could, including stress tests, cardiac imaging, echocardiogram, and everything they could see appeared normal. She was given nitroglycerin, which is a common medication given for chest pain in the field, but she had a bad reaction to the drug, which actually caused more problems than she presented with. The nitro had dropped her heart rate and blood pressure dramatically. So following her diagnosis of broken heart syndrome, she stated she is now very careful about stressful triggers. She stated that if she starts to feel stressed, she recognizes it immediately and does what she can to relax and stay calm. She also remains very healthy and has raised her own self-awareness about the condition. She states that she watches the foods that she eats and is generally more aware of things that she does so she can take more control of her life by further preventing another diagnosis of broken heart syndrome. Support for the following prediction was identified in this study. If research studies like this continue, then there may be improvement in the awareness and early identification of broken heart syndrome in the emergency medical field. Based on the questions asked and the answers obtained in the interviews, we can better understand the pathophysiology and the diagnosis of broken heart syndrome in emergency medicine. Stress cardiomyopathy cannot be diagnosed in pre-hospital medicine, but we as EMS providers can raise our suspicions based on signs and symptoms the patient may present with. As we have learned, broken heart syndrome tends to present almost identical to myocardial infarction or a STEMI. Signs and symptoms are also like those that are shown with acute coronary syndrome. Broken heart syndrome may be evident by ST segment elevation, chest pain radiating to the arm and jaw, and shortness of breath. There is strong suspicion of the pathogenesis mechanisms of broken heart syndrome, including catecholamine excess, microvascular dysfunction, and multivessel coronary artery spasm. Catecholamines are hormones that are released into the body as a response to stress, whether it's emotional or physical. The picture shown to the right is what EMS providers see on the heart monitor on the ambulance. At the top of the page on the picture, the EKG will show what it thinks is going on in the heart. As with this one, it shows that it senses STEMI criteria, which could be correct because the ST segment is elevated from the baseline. Although we cannot diagnose broken heart syndrome in the field, based on this EKG and what we understand about the disease, we can include broken heart syndrome as one of our differential diagnoses for this patient. As seen in this photo, the ST segment is elevated above the isoelectric line, which is the baseline the ECG is traced on. The ST segment can be elevated or depressed, especially in ischemia, which means there is not enough blood supply to the heart muscles. ST segment elevation, as stated before, is one of the key identifiable features of broken heart syndrome or a STEMI. This is a list of all of the references used for my research. Thank you to John and Chet for pushing me and encouraging me through everything and for all of their help with this project. Thank you for being there when I needed you. You guys have been so supportive through it all. And thank you to Dr. Chacon for taking the time to provide me with all of the information I needed to understand the pre-hospital care for broken heart syndrome. There's so much that goes on behind the scenes that I did not know about before, but I do now, and this can allow me to better treat and understand my patients. Thank you to Marianne for taking the time to talk with me about your experience and your life following your diagnosis of broken heart syndrome. It was a great eye-opener, and I now know that I can use that information for future patient contacts.